This program is brought to you by Emory University.
All right, good morning, everybody. We seem to have a good crowd here already. Welcome to Friday Morning Fellows Conference. Today is a journal club. We're going to have two presentations. First up is Dr. Matthew T. Brown, who is going to discuss the ECLS shock trial. Dr. Brown is a third-year fellow in our clinical track, a native of Gwinnett County, and aspiring advanced heart failure transplant fellow. So take it away, Dr. Brown.
All right. Well, good morning, and thank you for having me. PGY 6, the clinical fellow, and I recently had the opportunity to attend Emory's ECMO University course, which involved didactics and some simulations that were pretty impressive, involving ECMO, which I really hadn't come into too much contact with outside of the 5E ICU. So I wanted to take this opportunity to learn more, and there happened to be an ECLS shock trial that came out with the European Society of Cardiology's most recent meeting. So our objectives today are going to be review this shock trial, which was published simultaneously in the New England Journal of Medicine, and then kind of bolstered this evidence of this largest shock trial by reviewing a meta-analysis published by the authors that includes kind of 4 randomized controlled trials on the matter, published simultaneously in the Lancet. Consider shortcomings and the need for further investigation. But first, we got to start with a clinical vignette. So let's consider a 62-year-old male with hypertension, hyperlipidemia, non-insulin dependent diabetes, and tobacco use, who was brought into the ED as a code STEMI, and he had suffered a witness arrest in the park. He required 20 minutes of bystander CPR, excellent bystander CPR, and they got ROSC. EMS arrived on the scene. The post-arrest EKG showed an anterior STEMI. His blood pressure is 95/60, heart rate in the 90s. He's intubated, but he's still arousable. He's clearly altered. He's cold, clammy, not making much urine, and put a probe on his chest. His EF is 30%. He has a regional wall motion abnormality. And these are his labs. He's acidotic. His lactate's nearly 7. His creatinine is relatively preserved for the time being, and troponin climbing. So he goes to the lab. They find a proximal LAD lesion. PCI is performed, but his instability persists. So what is next for this patient? You revascularized, but he's showing signs of cardiogenic shock. What is best to support him in terms of therapy? Is it just inotropes or vasopressors to get him through this period, or should you start considering mechanical circulatory support? And over the years, we've gotten more and more tools in the tool shed. Today, we're going to be focusing and evaluating ECLS. But just for some background, 10% of acute coronary syndrome, STEMI and STEMI cases involve cardiogenic shock. And over the years, there's been high rates of mortality. And this is a trend that really has persisted. Outcomes still remain grim, 40 to 50% 30-day mortality. The shock trial showed the benefit of revascularization, but we've had several negative trials since that time, including the intra-aortic balloon pump shock 2 trial, which, with its negative result, kind of spurred the interest or the pivot to use ECLS. Over the past decade, there's been a tenfold increase in the amount of ECLS used, and really data is limited. So the authors in this trial decided to better evaluate, and they were able to recruit over 420 patients. We're going to be doing a deep dive into this article, and let's look at the methods. So it's a randomized multi-center, 44 to be exact, open label trial throughout Germany, mainly Germany, with one site in Slovenia. The treatment arms were ECLS plus medical therapy versus medical therapy alone. How the criteria and the criteria for enrollment was acute myocardial infarction associated cardiogenic shock, defined as SCAI stage C, D, or E, and we'll go through that, with planned revascularization. So in terms of SCAI stages, these other criteria needed to be met. Systolic blood pressure less than 90 for 30 minutes, pressor needed to maintain, organ malperfusion, and then authors added an enhancer here of an arterial lactate greater than 3, just to kind of move the needle and ensure that patients were having organ malperfusion, and they did a good job at it. So the exclusion criteria was CPR greater than 45 minutes, mechanical causes, some sort of valvular issue, shock greater than 12 hours, pregnancy or severe PAD that was a contraindication to ECMO cannulation. But first, as we delve into things, let's remind ourselves what exactly SCAI stages are. And this is our SCAI stage analysis. And we have a nice recent trial, retrospective review that looked at a good number of shock cases, that gives us a mortality correlate. So we're focusing on these 3 stages of shock. C being classic, the patient with signs of malperfusion, who's needing an inotrope, who's needing some sort of mechanical circulatory support. D is deteriorating. They're not doing well despite that support. In extremis, they may have or have had circulatory collapse and needed CPR. Now, the SCAI stages and mortality correlates for this. In the top, you have total cardiogenic shock with both acute MI and heart failure associated. Down below, you see they've separated this out into acute MI or cardiogenic shock or heart failure related cardiogenic shock. And you see that in all groups, all stages, acute MI has much higher mortality. And D and E, we're pushing into the 40-50%. E is even above 50%. So these are sick patients from the get-go. And it makes you wonder about where should you be thinking about drawing the line. Now, this is the protocol that they used, and the protocol documentation is, almost over 100 pages. And they had very specified endpoints and reasons to do certain things all throughout. Now, they screened patients across these 44 sites. Anybody that was not suitable, but for one reason or another, and was sent to a shock registry. So they didn't lose out on that data. But as people were randomized, the main kind of intervention was ECLS insertion. And this happened in the cath lab, whether before, during, or after the PCI. And then the intensive care unit arms and the follow-up periods were very similar. And there was many specified endpoints for care during that time, many lab values to get and follow. Now, the one adjunct is in the control arm. There is this escalation to therapy that involved escalating therapy to include mechanical circulatory support. They recommended not crossing over to true ECLS, but rather trying other devices like the intravenous balloon pump, the Impella, the tandem heart, if there were cases of worsening or deterioration despite PCI. So that is something that we'll look into as we delve into this study. But first, a reminder about VA ECMO. It consists of large bore catheters, drawing blood out of the venous system and putting it through a pump that oxygenates the blood, actually can ventilate it as well, and then returning that oxygenated blood back into, in this case, the femoral artery, where there is retrograde perfusion. Now, so typically this is done with the femoral vein, a venous drainage catheter that is very long and large bore, 21 to 29 French. Here they use 25 French typically. This is put into the femoral vein and threaded all the way up, basically into the right atrium, where multiple holes or multi-stage catheters are used and draw that venous blood out, pump it through an oxygenator, and then the blood is returned through the arterial limb of the sheath, which is typically, in this study, it was 17 French going into the opposite leg's femoral artery. Now, as you have that large catheter there, they highly recommended using a distal reperfusion catheter downstream to try to prevent limb ischemia. So it's a very complicated system with large bore catheters, and you can imagine bleeding rates and the potential for embolism. But let's think about the outcomes after reviewing VA ECMO. In this case, the primary outcome was death from any cause at 30 days. They had various other secondary outcomes, but another point of interest is safety for just those reasons: moderate to severe bleeding, stroke, systemic embolization, and vascular complications warranted intervention. So they had many statistical considerations as they put together this complex trial. They assumed we're shooting for 80% power. So based on prior data, they targeted enrollment at 394 with a 6% estimated withdrawal rate and shot for our 420 patients to be enrolled. They wanted to analyze with an intention to treat, which can get complicated. And they had many specified subgroups, including lactate level, interior MI versus others, and then CPR versus no CPR. But one subgroup that's missing is that SCAI shock classification that we reviewed. So moving into the actual enrollment, they assessed over 870 patients. 450 of those were excluded for one reason or another. These are listed here. And they got to their number for randomization of 420, 211 in the ECLS arm, 209 in the control arm. Now, what you'll see is that certain amounts in each of these arms did not receive the appropriate therapy or the allocated intervention. And I was interested in why that may be. But in the ECLS group, it was because 17 patients, out of those 17, 4 patients died prior to ECLS insertion. And then 13 patients, they more or less reevaluated, and there was either a contraindication or a primary condition, the severe cardiogenic shock, was no longer an issue after revascularization. Now, looking at the control group, which I found more interesting and I think speaks to the severity of illness in this population, is 22 patients didn't receive the allocation. And that was because mainly clinical deterioration, which majority of the time involved refractory cardiac arrest, prompting them to cannulate for VA ECMO within the first 24 hours. So I think you're getting the gist of how sick this population that they've recruited is. So let's delve into the patient demographics. And what we find is that the majority of these patients were low 60s, middle-aged. 80% of them were males. They're overweight with risk factors, hypertension, hyperlipidemia, smoking, diabetes. 10% or so had varying levels of ASCVD already. And on presentation, they very much were consistent with shock physiology, altered mental status, cold, clammy, not making urine, narrow pulse pressure with kind of high normal heart rates. So looking at the disease characteristics upon movement to the cath lab, 2/3 had presented with STEMI presentations. And among those STEMI presentations, or just presentations in general, 2/3 of patients had multivessel disease. Majority of the time, this was LAD territory, but 10% had left main as well. There was shown to be a moderate severe reduction in EF, with the medians around 30%. And lab values showed a severe acidosis with lactates greater than 6. That's a median value there, a relatively preserved renal function. And what I really want to point out here is that nearly 80% of patients in both arms underwent CPR, and the median duration in both arms was 20 minutes of CPR. Now, looking at the SKY shock stages, we see that 50% presented in classic cardiogenic shock. That's that C level, where patients are showing signs of organ malperfusion, needing some sort of therapy. But 33% between the two groups presented in extremis, which just shows how sick these patients were, and is important to consider as we think about it. Now, the clinical vignette that I showed you originally is exactly all these median values. And I hope it triggers, it paints the picture of someone in this situation. This is just the average patient in this study, which I thought was very striking. Now, thinking about the treatments, we have primary PCI in the majority, with good restoration of flow, and about 20 to 25% proceeding on to do a non-culprit intervention in those multi-vessel disease patients. Now, ECLS was typically initiated post-PCI in the cath lab. I think that's not exactly what they were going for, but they were hoping for before. But I can't imagine the clinical situation. And it's impressive that they were able to get this done. So 2 to 3 days of ECLS duration on average, and over 95% in the ECLS group used distal reperfusion. One thing to note is that there was minimal use of left ventricular venting or unloading, less than 5% or less than 6% in the ECLS group, but a much higher rate, 31% in the crossover from the control. And I think that this just means that this is a bailout in the control group. Now, why is this important, and why was this kind of seen as taken as a criticism, and why did they avoid it? So the authors cited in their protocol that despite a potential benefit in mortality of venting systems, there is significant potential risk. Therefore, they recommended that in cases not involving clear afterload increase, that it's not performed on a routine basis. And these were some of the criteria: pulsatility being an issue, LVOT-VTI being less than 10, or the aortic valve not opening on echo, as criteria to consider venting maneuvers, which involve balloon pumps, impellas, even creating an atrial septostomy. So what is this data that they refer to, the mortality benefit? And we deviate a little bit here, but there was a study done in 2020 that looked at a retrospective review of about 600 cases, 60% of which were AMI-associated cardiogenic shock. And they looked at patients that had been cannulated for ECMO. And of those patients, they compared the patients with just ECMO to those with ECMO and some sort of LV venting. And they actually saw a significant decrease in the probability for any death at 30 days. Now, this was an impressive signal, but they had to weigh the risk of moderate to severe bleeding, which was much higher in the ECMELA group or ECPELA group, hemolysis, intervention because of site-related ischemia, laparotomy, and then renal replacement therapy approaching 60%. So you got to take the bad with the good there. Now, more data has been reviewed to look at the timing of active left ventricular unloading, and shown that earlier LV unloading is more beneficial or reduces the risk of these complications from occurring. Now, getting back to our population in that control group where many were used as a bailout, it's interesting to see this data and put it into that context. So, jumping back to our study after a little deviation, it was impressive to also look at the treatments and really what happened in the control group as 28 patients crossed over or needed escalation of therapy. Now, when you include the 12% that crossed over to ACLS, this brings about the control group, 25, a quarter of the control group either had mechanical circulatory support, which is mainly an Impella CP, or, the other half crossed over to ECLS. So one thing that really was prominent was this minimal use of LVADs. Only one patient in each group went on, if we're thinking about ECLS as a bridge, went on to get durable left ventricular support. No patients were even described to be considered for transplant. And their primary endpoint was largely negative, which after reviewing the severe illness of people is very humbling. This was the intention to treat analysis, and you can see from the bottom, 47.8% of patients died in the ECLS group, 49 in the control group. You do see a little bit of signal early on, maybe at day 10, where there is a gap. You can fit a laser pointer in between there, but that closes rather quickly. And, one of the criticisms here was also there's a high rate of MCS use or ECLS use within that control group. So I liked how the authors went ahead and did a per protocol analysis that didn't show anything different. This is purely ECLS, purely no ECLS. And you see that same trend early that's lost late. And then this is as treated. So some of our secondary endpoints didn't show anything positive, but there was a significantly increased risk of severe bleeding, over nearly 2.5-fold, and then approaching 3-fold increased risk of peripheral vascular complications. No differences among subgroups. That includes those in the ACPR group and the arterial lactates. And this was also seen in the randomized controlled trials that were included in the meta-analysis to increase the N number to nearly 600 patients. Again, moderate severe bleeding and peripheral ischemic events were very elevated in this population too, when taken into account. So our main conclusions, this is the largest randomized control trial. It's an extremely sick patient population. There's no difference in 30-day mortality. However, there's this very positive signal, both for severe bleeding and peripheral vascular complications. How does it relate? Aspects that I'd be interested in would be exploring why more patients were considered for durable LVAD support and or LV venting. But I think there's some future considerations, future trials, like danger shock, unload ECMO, and recover 4 that are in the pipeline to be able to help us better answer these questions. So I really thank you for your time. I've got a list of references here, and I want to give a shout out to Dr. Dickard, who helped me help discuss this article with me, and then also Dr. Joshua Chan, who provided some of the VA ECMO slides. Thank you.
Thanks, Matthew. Very good. A few minutes here for discussion. I mean, you sort of alluded to it a little bit, but why do you think there wasn't a bigger benefit, at least, more durable benefit in this, in this study? You're right. It's a little surprising how negative it is. So what are your sort of unfiltered thoughts, maybe?
Yeah, I I think I was most impressed at just how sick the patient population that they recruited was. I mean, to have patients, 80% of the patient's population undergoing CPR for a median duration of 20 minutes was very impressive. And I wonder the state and the condition of those patients. They did do neuro status monitoring, and um, I think it would have been very, very nice to have a subgroup analysis based on the Sky Shock classification. I think that would have been telling. And in hindsight, being this a negative study, it could be evaluated to see if there was any signal among these different sky stages to be able to help guide uh, better criteria for picking patients that are thinking about candidacy.
Josh, this is Khusro Niazi. Great presentation. You presented the data very clearly. It would have been interesting if they had a third arm using intra-aortic balloon pump very early on. I know in the control arm, they were allowed to use it, but they only used it if the patient deteriorated. I just wonder, since most of the ECMO was placed post-procedure, in the cath lab when we have STEMI with cardiogenic shock, many times we just rush into placing a balloon pump and then go ahead and revascularizing them. And I just wonder if earlier use of simpler devices with less complications would have altered or shown some efficacy.
Yeah, that is a great idea, and I think maybe not the balloon pump, but there's many trials in the pipeline looking at the Impella CP, and then this is of particular interest, this unload ECMO, which involves the ECPella configuration. But yeah, it's hard to think about Impella as a first line when you have a balloon pump that's so much more inexpensive, although may not be able to deliver that amount of circulatory support. But it'll be interesting to see how things shake out with these trials that are coming up.
Yeah, I think I would just add to Khusro's point, the Recover 4 is a good example of that, right? That's protocolized pre-PCI use of Impella. So some of this question about whether early unloading, particularly in the intervention stage, is helpful. And we'll learn something from trials like that. I can't remember whether Danger actually protocolizes that component or not, but I think we'll get more insight into the value of the early piece. I think the piece that I was going to just emphasize, I think there's sort of two mysteries to me, or maybe three in this study. One is, it is interesting. They have in the little bit of subgroup analysis they do, the patients, for example, who didn't undergo CPR and whatnot, they're strikingly not positive. I think that's a surprising finding, because probably the easiest way to pick at this study is to say, look, these people were so sick, many of whom are 90% are intubated, most of them are coming in having or half of them have come in having CPR. It is surprising that group didn't, that were even closer to the null. The second is that early signal of benefit at 10 days or so that then deteriorates, I think, is a little mystifying in terms of is there something we can do kind of afterwards? I think about our population. A lot of times, if someone is 10 days post AMI cardiogenic shock, we're thinking durable LVAD, other kinds of longer term therapies, and kind of what we do from day 10 on. You wonder, are there ways to improve in that space? Because that's a pretty appreciable difference if that were to persist. And then I think the other piece is just these are really sick folks, and I think it's there's a real question about whether we can really sort of target the shock stage C, and particularly shock stage C, where we potentially have probably the greatest opportunity to make improvements. There have been, some questions about, I think this isn't in the protocol or in the papers, but what did the withdrawal of care sort of parameters look like after that 10 days and whatnot to potentially explain some of these issues. It's hard to know exactly sort of why that happened, but it's a humbling finding, and I think certainly suggests that things that the big takeaway for me is the things that we think ought to help don't always make a difference in the way that we think they should, and this is why we do trials. We just have to find the right population and the right use and the right tool. I don't think we found that yet in cardiogenic shock.
All right,
Josh, Robbie, one quick question: did the younger people do any better?
And they performed a subgroup analysis on less than 65, greater than 65, and there is no signal there either.
Thanks.
That's as much as they broke up.
All right. Well, thank you, Matthew. We'll move on to our next article. Our next speaker is Karagiannis, one of our also third-year clinical track fellows. As I'm sure most of you know, Aggie's originally from Greece, did his residency here at Emory, and is going to be an interventional cardiology fellow next year. He's talking about the CLEAR Outcomes trial. Take it away.
Thank you so much, Dr. Williams. Hey, everyone. I'm excited to be here with you today. I'm also very excited about our topic today, which is about bempedoic acid. So bempedoic acid pretty much is like the new player in town when it comes to hyperlipidemia management. And also today, we're going to delve into more details about bempedoic use and pharmacokinetics. And also, we're going to discuss about CLEAR Outcomes. This is the recently published trial of bempedoic acid and its effect on cardiovascular outcomes. We can't have any discussion about hyperlipidemia management before we start talking about statins. Statins, as you know, is the mainstay when it comes to management hyperlipidemia. It has been proved that it reduces cardiovascular risk in both primary and secondary prevention patients, and it improves cardiovascular outcomes. And it's always the first line when it comes to guidelines in management. However, up to 30% of patients, at some point, they might experience some statin-associated muscle symptoms, also known as SAMS. And these symptoms might prevent them eventually from using statins or from taking statins to the guideline recommended doses. And then it has been shown in several studies that withdrawing from statin therapy is associated with increased risk of adverse cardiovascular events. So clearly, and pun is intended here, we have very room to improve. So two recently published studies as well show that for primary prevention patients, only 17%, and for secondary prevention patients, only 22% achieve their treatment goals when it comes to LDL cholesterol, according to the a little bit more strict guidelines of 2019, the European guidelines compared to the American ones. But still, only 22% achieve their goals. And then in other studies, like in a meta-analysis, it was shown that up to 49% of patients were actually non-adherent to statin within 1 year of follow-up. So here comes bempedoic acid. A little things about bempedoic acid. So first of all, bempedoic acid is an oral medication. It's an ATP citrate lyase inhibitor. It actually targets, as statins do, targets de novo cholesterol synthesis in the liver. And therefore, it actually reduces the hepatic cholesterol synthesis and also raises LDL-C receptor expression and subsequently LDL-C clearance from circulation. It's very important to understand that bempedoic acid is a prodrug, and it's converted to its active metabolite by an enzyme located mostly in liver cells. This enzyme that is very necessary, very important for the for activation of the drug, it's absent from the muscles, and therefore bempedoic acid has this big benefit of potentially having lower risk for myalgias and myopathies. Here's a slide here that shows actually the mechanism of action of bempedoic acid. This is like its first manufacturer name, like its experimental name. Bempedoic acid is a prodrug, is inactive. It goes into the hepatocyte, and then this enzyme activates it into its active form. Bempedoic acid, therefore, inhibits the ATP citrate lyase, which is like, again, it's an enzyme essential for the de novo synthesis of cholesterol. And this is upstream compared to where statin acts, like on the HMG-CoA reductase. Importantly, this enzyme that is activating the bempedoic acid is absent from the muscle cells. Therefore, there is no bempedoic acid inside the muscle cells to inhibit any kind of enzyme pathways, and therefore myotoxicity is less observed with bempedoic acid. In contrary, statins act both in liver cells and myocytes. Some characteristics, pharmacokinetic characteristics for bempedoic acids. Again, it's an oral medication. You can administer it once daily. It's a prodrug, and its half-life is 15 to 24 hours. There are like minimal drug-drug interactions with bempedoic acid. Most importantly, it interacts with simvastatin. It has been shown that it mildly increases simvastatin levels, and therefore it's recommended that you don't use more than 20 milligrams simvastatin concomitantly with bempedoic acid. And also, importantly, bempedoic acid inhibits renal tubular OAT, or OAT2, which subsequently raises uric acid levels, because this is the same transporter that is used for uric acid clearance. There have been so far several studies prior to the clear outcome study. There have been several like large-scale studies assessing its impact and its effect on several biomarkers, like clear serenity, clear harmony studies. So bempedoic acid has been shown to decreases total cholesterol, decreases significantly the non-HDL cholesterol, the LDL-C, the LDL particle numbers, the lipoprotein B, but it also decreases the HDL-C and the HDL particle numbers. Interestingly, bempedoic acid and statins, I think, are the only lipid-lowering agents that also decreases CRP, and this is an inflammation marker, right? What it doesn't have impact on, it doesn't have any effect on triglycerides, on apolipoprotein A1, and on a very low LDL. Unfortunately, it has been shown that bempedoic acid increases serum uric acid levels, liver enzymes, as well as creatinine. When it comes to LDL-C reduction specifically, a single dose of daily bempedoic acid with 100 milligrams daily, it has, as a monotherapy, 25% LDL-C reduction. When it is used on top of high-intensity statin, it adds an additional 18% LDL-C reduction. And then when it is used fixed with ezetimibe daily, overall, these two together medications reduce LDL-C levels by 40%. And then my favorite one is right now, we literally have this bomb regimen that in patients that we can give high-intensity statin plus ezetimibe plus PCSK9 inhibitor plus a bempedoic acid, and these patients have at least like some LDL receptor activity, we can decrease the LDL-C by more than 85%. So we have the power right now to literally eliminate almost LDL-C levels. So we know that bempedoic acid, we know that it has a very positive impact on reducing LDL-C and cholesterol in general. It also reduces significantly CRP levels. However, what its impact on cardiovascular outcomes? And this is the answer we're going to get today from this trial. This clear outcomes trial was just recently published a few months ago in April 2023. and it evaluates the impact and the effect of bempedoic acid on cardiovascular outcomes in statin-intolerant patients. As far as organization of this trial, it was a double-blind, randomized, placebo-controlled trial. It was designed by the sponsor and the manufacturer of bempedoic acid, Esperion Therapeutics. It also was in collaboration with the Cleveland Clinic Research, and there was also some independent data monitoring committee that actually reviewed all the safety and efficacy data during the trial. In regards to the trial's population, that was a very large-scale trial. Almost as many as 14,000 patients were participants, and they were among like 1,200 sites in 32 different countries. The age was from 18 all the way to 85 years old. And then there were actually both patients with secondary prevention patients, like patients that have already had experienced a cardiovascular event, or high-risk patients for like primary prevention patients, high-risk for cardiovascular events patients. Also, all these patients have been deemed to be statin intolerant patients, and I can like there was some data on supplementary data about how they define statin intolerant patients. And interestingly, some patients that they could tolerate very low daily statin doses, and specifically like less than 5 milligrams of rosuvastatin or 10 milligrams of atorvastatin, they were also deemed to be statin intolerant patients, and they were also included in this study. This study also allowed all these patients that have been on other lipid-lowering therapies like ezetimibe, PCSK9 inhibitors, they were also included in the study. And then all these patients were forced to sign that they were aware that being off statins, they have an increased risk for cardiovascular events. So as far as the randomization of this trial, first, what they did, interestingly, they ran a 4-week running period to filter out all the patients with that they wanted to include. And I'll tell you how this running period started. So they did, for all the patients, they did this 4-week running period just giving single blind placebo. So patients weren't aware that they were only given placebo. During these 4 weeks, if these patients on placebo were experiencing intolerable adverse effects, or they were non-adherent to the medication, the placebo, all these patients were dropped out. The rest of the patients, were approximately almost like as many as 14,000, they were randomized in a 1-to-1 ratio to receive either daily 180 milligrams of bempedoic acid versus placebo. At 6 months, they if their LDL-C levels in all these patients were more than 25 of the baseline level, then the investigator was notified, and then they were able, the investigators, to switch and change the lipid-lowering regimen to improve their LDL-C levels of the patients. In regards to the trial's endpoints, the primary endpoint was a 4-component composite of MACEs. Specifically, these 4 components were death from cardiovascular causes, non-fatal MI, non-fatal stroke, and coronary revascularization. There were also some secondary key endpoints, which was a 3-component composite of death from cardiovascular causes, stroke, and MI. There were also independently, there were endpoints for MI, coronary revascularization, non-fatal stroke or fatal stroke, death from cardiovascular causes, and then death from any cause. As far as the baseline characteristics of the patients and the participants of the study, they did a pretty great job in randomizing them. There wasn't any category with statistically significant difference between the placebo group and the bempedoic acid group. Some characteristic was that the mean age was approximately 65.5 years old. There were actually many female participants. There's 48% of the participants were females. 45% of the participants had diabetes. 70% they were for secondary prevention, and 30% were for the primary prevention. 22% of these participants were already on a statin, 11% on ezetimibe, And then at baseline, the mean LDL-C levels were like 139 milligrams per deciliter. The median follow-up of the study was 40 months, like approximately 3.3 years. And then there was a high premature discontinuation of the trial regimen, which occurred in 29% in the bempedoic acid group versus 31% in the placebo group. However, the duration of exposure to either bempedoic acid or placebo group were similar. And then in the end, a complete assessment of the primary endpoint was available for 95.3% in the bempedoic acid group and placebo group together. And then the vital status was like available for 99.4%. So great completion data overall. So let's take a look on the results of this study. First of all, in regards to the impact on the LDL-C levels, this study confirmed that that bempedoic acid significantly reduces the LDL-C levels. At 6 months, it reduced by 20.3%. And then when it comes to high sensitivity CRP levels, it also confirmed that at 6 months, there was a median percentage of lowering it by 21.6% in the bempedoic acid group. When it comes to the efficacy endpoints, the study was positive. So it showed that actually bempedoic acid significantly reduced the primary efficacy endpoint, the 4-component MACEs, by 13%. So there was a hazard ratio of 0.87. And then this reduction, these positive findings were mostly driven by reducing the fatal or non-fatal MI by 23%, and also by reducing the need for coronary revascularization by 19%. In contrary, bempedoic acid didn't have an impact on the stroke incidence or any death from cardiovascular causes or any death from any cause. Again, these are some graphs that show how bempedoic acid has a positive impact on the 4-component MACE, the fatal or non-fatal MI, and the coronary revascularization. It decreased the risk reduction from the primary endpoint by 13%, and then it had like a 23% reduction on the MI and 19% reduction on the coronary revascularization. Unfortunately, bempedoic acid came with some adverse effects. Specifically, it was associated with elevated biomarkers, including like elevated hepatic enzymes level, 4% in the bempedoic acid group versus 3%. Elevated serum creatinine, 11.5 versus 8.6. Incidence of hyperuricemia, 10.9 versus 5.6. Incidence of gout, 3.1 versus 2.1. And then also incidence of cholelithiasis, 2.2 versus 1.2. What it didn't have any impact on was myalgias. So there was only 5.6 myalgias, like incidence of myalgia in the bempedoic acid group versus 6.8 in the placebo. And there was not any difference between the groups when it comes to discontinuation of the trial just because of myalgias. Also, as we know, statins have been associated with some like mild A1C elevation and some increase in new onset diabetes rates. This wasn't observed in bempedoic acid group, where there were actually no difference between new onset diabetes in patients that were in the group of bempedoic acid versus the placebo group. Overall, the incidence of adverse events, serious adverse events, and adverse events leading to discontinuation of the trial did not differ meaningfully between the two groups. Limitations of the studies, there weren't that many. Like, study actually was pretty well organized and has a pretty good number of patients. The follow-up was only 3.3 years. So we only have right now kind of intermediate follow-up. We obviously might expect like more adverse effects or more benefits if we are monitoring these patients for a longer period of time. Although there was a significant representation of women almost like 50% white population, Latino populations, there was underrepresentation of African American population. And also, lastly, there was like these effects of bempedoic acid on cardiovascular outcomes was in patients who have already have had like like high kind of LDL-C levels, like mean of 130 milligrams. So we don't know how big of an impact they have on patients with lower LDL-C levels, and also we don't know how big of an impact bempedoic acid has on patients that are on conventional therapeutic doses of statins. So few last things is that as far as FDA approval, bempedoic acid with a brand name called Nexletol has been actually FDA approved, and also like in Europe has been approved too, as an adjunct to diet and adjunct to maximally tolerated statin therapy for the treatment of adults with heterozygous familial hypercholesterolemia, or for patients who have already established cardiovascular disease, but require additional lowering of LDL-C levels. In regards to its cost, it's pretty expensive. It's for an oral medication. It's like for 1 month, like for 30 tablets, its cost is approximately $400. And this is either like as a monotherapy, like Lexletol, or as a combo pill, which is called Nexlizet, and it's like a bempedoic acid plus ezetimibe combo pill. And then actually this cost is almost similar, if anything more expensive than PCSK9 inhibitors, if a copay is used. And then a few things that they haven't been addressed yet is, first of all, it hasn't been updated in any guidelines. Like there's no, like either the 2019 European guidelines or the 2018 American guidelines, they haven't included it in their algorithm when it comes to management of hyperlipidemia. And also there is no, specific like data in regards to show whether or not we should measure like some specific markers like uric acid or creatinine or liver enzymes prior to its initiation. So these are a few things that the guidelines might need to update. And this is pretty much about bempedoic acid. Thank you so much.
Thank you, Aggie. Very good summary of those findings. I guess, right, you'd mentioned sort of how it would compare with sort of, I guess, compare and contrast with the ezetimibe. I mean, it's sort of on ezetimibe's corner, right, in terms of alternative therapy, in terms of efficacy, that sort of thing. What are your thoughts on, on those two drugs?
Yeah, exactly. So right now we have like longer experience with ezetimibe, and ezetimibe is way less expensive. So I think it still should be our second agent when it comes to patients that haven't achieved the LDL-C goal levels. And also, it's interesting, like in IMPROVE trial of ezetimibe and here in outcomes, bempedoic acid might be just slightly more potent. Like ezetimibe reduces overall like around like 20% of LDL-C lowering, whereas bempedoic acid can be a little bit as high as 25%. But still, at this point, I don't think bempedoic acid should be used prior to ezetimibe in this population.
Angus, this is Khusro Niazi. Great presentation. With the oral PCSK9 trials going on, and hopefully in a couple of years, if we have that available. But even currently in my practice, I still prefer PCSK9 injection as compared to bempedoic acid because this has got some side effects. Can you explain, since it doesn't act in the muscles, why is the CK rise happening in patients who are taking bempedoic acid?
Yeah, that's a great question. So I agree as far as the first part that PCSK9 inhibitors we have more data, and characteristically they have less side effects compared to bempedoic acid, and also PCSK9 inhibitors have more robust and potent decrease in LDL-C, so they should be first, unless the patient is really adamant about not getting any injections. As far as the second part, there's no real knowledge out there why they're doing that, why it increases like the CK. It's characteristically doesn't have any impact like on symptoms. So they were actually perplexed. The increase is not that high, but still it's statistically significant. But there's no mechanism to to explain that.
Thank you.
Angelo, Stan Sherman, good talk. Given the cost of this medication and the fact that it's probably not in the guidelines, do you know anything about the insurers? Are they picking up the bill or not really?
Not really. I mean, I was looking at that out, like for PCSK9 inhibitors at this point, we have like insurances paying and then participating into the cost. For bempedoic acid, I couldn't find any insurance co-payment to my knowledge. Not that I'm very experienced with that. I would say maybe they were waiting for maybe okay, perfect. Dr. Mehta just said that there is actually one patient that insurance approved it, but had to write a letter to justify the need. Yeah, so it's more of a bothersome right now, but I think like once guidelines update its use, insurance companies might be a little bit less reluctant to participate.
Thank you.
Dr. Smith says that it's covered by the VA. That's nice.
Elena here. I had a provocative kind of question. In your practice, Adi, are you following European or American guidelines in terms of LDL goals?
I'm more of an aggressive guy, and that's a very good question. Like European guidelines, they're more aggressive. And since we have data to support that the lower LDL-C levels, the better. Even though I don't write this in my note, I'm more aggressive. So I would like to know. I wouldn't be scared if the LDL-C levels drop down to 30, and I wouldn't change the regimen there. And also, like, I would be more on the aggressive side, like more on the European side. And I think like the American guidelines will soon update, and they have already done actually. Like they already dropped the limit down to 55 in some patients, high risk patients.
The preceding program is copyrighted by Emory University.